The same position is done for the AP L5S1 spot and the AP SI joints. And so I included this projection with the SI joints because not many clinical sites do the AP L5S1. But if they did, it would be done exactly the same as the AP SI joints. So we're starting at 40 inches and we're gonna angle 30 to 35, 30 for males, 35 for females. So if I angle 30 degrees, and if I'm dropping an inch for every 5, I would come down 6 inches, right? 5, 10, 15, 20, 25, 30. So I'm gonna drop from 40 to 34, and that gives you about the correct SID. So I'm centering here, and then I want roughly 8 by 10 collimation. And this is a 10 by 12, so I'm collimating in about an inch on all 4 sides. AP L5S1. I have run out of room here, so what I'm going to do is just pull my patient down, and I'm going to pull him farther than he needs to go, just so I've got a little bit of leeway when I'm coming back up this way. So I'm on his mid-sagittal plane. Okay. I'm going to palpate for ASIS. And my central ray is going to enter about 2.5 inches below that. Okay, so it looks fairly low, but by the time the central ray passes through the body and is passing through the spine, it should be right about the junction of L5S1. Now the 30-degree angulation has to do with the fact that the lordotic curve of the back, by the time we get to where it's joining the sacrum, it's probably at about a 30-degree angle, and I want my central ray to pass through that joint space. So 30 for males, tighter collimation. It's kind of difficult to do this position when the patient's got their knees completely flexed, but because it's more comfortable for them to have some bend in their knees, I've just offered the patient a knee support for this projection. So his knees are down out of the way, but he's still got a little bit of comfort. And he would suspend breathing. My right marker's inside the field of view. I could shield for this, but again, as long as it's outside the collimation borders, that should be good. Hold your breath and expose. All right, now we're going to move into the AP, this is a AP SI joints or AP L5S1 spot. And then if you were doing SI joints, sacroiliac joints, we have to do a right oblique and a left oblique. The sacroiliac joints sit at about a 20-degree angle. And so when I roll the patient, let's say, into an LPO position, now this SI joint is vertical. So my central ray should pass straight through it. And then I would go RPO and aim for the elevated side. So you're on SI joints, you oblique the patient about 15 to 20 degrees. I'll check the textbook. And you're aiming for the elevated side. I'm going to do the oblique sacroiliac joints. I'll be doing the side elevated. And again, because I still have to do a lateral sacrum coccyx, I'm going to do the RPO first, then the LPO, and then the lateral. So this is not a 45-degree oblique, this is only a 20-degree oblique, so I'm using the steeper side of the sponge. So if you could bend your left knee for me and roll just slightly towards me, I'm gonna place a sponge behind you. Bring this arm over. Okay, let's make sure you're straight. So he's obliqued about 20 degrees. Straighten this leg now. Okay, I'm going to be feeling for ASIS. Okay. Centering 1 inch medial, directly medial to the ASIS. So it comes to a point. I've palpated ASIS and I'm centered 1 inch medial to the elevated ASIS, and this should get that SI joint brought up vertical, and now the central ray of the beam is passing through the SI joint. Can't feel your ASIS. Stop. Sorry, is that it?
Well, here's my crest here.
I know, ASIS.
I should, yeah, right there.
Okay.
Press any harder and
Stop. Okay, so that's my RPO for the left SI joint. Okay, we're gonna do the other side now. So roll up just a little bit. And take this sponge out, and now you're gonna roll just slightly to your left. Come back. Right. No, keep your legs uncrossed. Thank you. Okay. ASIS. 1 inch medial. And now I'm showing the right SI joint in the LPO position. So I would swap out my IR, place my left marker because he's in an LPO position, but it's on the left, it's on his left side. So even though I'm visualizing the right SI joint, I'm marking the side that's down because I am showing both sides of the spine. If I marked it right, it might be a little bit confusing. So I'm marking the side that's down. Suspended respiration on this. You can shield on both of the obliques. Okay. He'd suspend breathing and expose. Okay, now for the lateral sacrum. So we flipped back and forth here. I did, this is SI joints, and then I want to do sacrum coccyx as well. So because you're already almost in the lateral position, I'll demonstrate the lateral sacrum first, and then I'll come back and do the AP sacrum coccyx. All right, I'm going to take this sponge out and have you slide back toward me just a little bit with your more with your shoulders. Okay. Good. Okay. So this is the lateral sacrum coccyx. Now I've kind of jumped ahead. We just finished SI joints, and the AP view is also the same projection for an AP L5S1. So now that I'm moving on to sacrum coccyx, I'm going to start with the lateral, since if this was a series that I was doing, this would be kind of the logical sequence for it. This can be pretty tightly collimated, maybe to about an 8x10, because I am getting the entire sacrum and coccyx on here. So if I have a 10x12 now, I want to be at an 8x10. That's about right. I'm going to feel for your front of your pelvis here again. Okay. ASIS. I'll be about 3.5 inches posterior and I think 2 inches inferior. I'll double check in the textbook.
Sounds right.
So 3.5 posterior and then 2 inches inferior using ASIS as my starting point. Yeah, I've got a really small ASIS. I can barely feel it.
Well, I am Native American.
What does that have to do with it? Okay, so 3.5 posterior, 2 inches inferior. And keep in mind, I mean, he's got, you know, you have your gluteal muscle back here, which has got, it's a pretty thick muscle. And so you have to think that, you know, this, even though, you know, we think of this as being our tailbone, it is inside the tissue. So depending on your patient's body habitus, it's best to use your bony landmarks rather than looking at soft tissue, because if you had a patient with a lot of soft tissue and you were centered way back here, you'd miss it. So go by your bony landmarks, ASIS, 3.5 back, 2 inches down, and that is going to get most people's sacrum coccyx. So that is our lateral projection. I could shield here and suspend respiration, expose. Okay, we demonstrated the lateral sacrum coccyx, and now we're going to demonstrate the AP sacrum coccyx. And the easiest way to remember this, so cephalad and caudad both start with the letter C, but they make 2 different sounds. So if you remember that sacrum goes with cephalad and coccyx goes with caudad, you'll never forget. Mm-hmm. Okay, so sacrum is a 15-degree cephalic angle. So I'm starting at 40 degrees. I'm going to come down 3 inches, 1 inch for every 5 degrees of angulation. So my SID is 37. Okay, I've got about an 8x10 collimation. Got my right marker on here. And this is going to be, now remember, we have a lordotic curve in our back and then the sacrum angles. So I'm trying to come in perpendicular to the slope of the sacrum, which is about 15 degrees. Be centered on mid-sagittal plane and approximately 2 inches inferior to the ASIS. So I'm looking at the front view of his sacrum. Okay, mid-sagittal plane, palpate ASIS, down 2 inches, and I've adjusted my SID for my 15-degree angulation, and that is our AP sacrum. For the AP coccyx, you're going to now go caudal. Coccyx is caudal, but it's only 10 degrees. So I'm going to go 10 degrees caudal. I can come up now another inch because I've added 5 degrees, so instead of 37, it's at 38. Okay, and then readjust my center. But my entrance point is going to still be about the same. So I'm feeling for ASIS, and I'm going to enter about 2 inches below. Now the sacrum finishes angling, the coccyx curves back up slightly, about 10 degrees. So I'm trying to match the curvature of the coccyx with my caudal angulation, and that is our AP coccyx. Suspend breathing, expose. Now you can shield for these, just make sure that your shielding is outside the field of view.